Hi friends, let's have a look at this short case scenario where there is an infant who presented to ER with complaints of abdominal distension and absolute constipation for the last 2 days. When you take a proper history, the infant mother tells you that prior to this episode of distension and constipation, he had about 15 episodes of loose stools or watery diarrhea. When you examine the infant, you find him to be dehydrated and he is having tachycardia. The abdomen seems to be soft, it is non-tender, and it is distended. When you auscultate, the bowel sounds are totally absent. When you do a radiological examination, you find on X-ray there are distended bowel loops with gas present up to rectum. There is no air fluid level. And on the blood investigation, the most remarkable thing is that the potassium level is very low. So we are dealing with an infant who has presented with features of intestinal obstruction, and at the same time, what we are finding is his potassium level is low. So what should be done? What should be the diagnosis? Should we rush the patient to OR for surgery? So what is the diagnosis here? Friends, here we are discussing a special type of intestinal obstruction where there is no need to hurry or rush up for surgery, and most of the patients are being managed conservatively. This is a case of adynamic intestinal obstruction or paralytic ileus. Adynamic means without movement, means the patient is having an intestinal obstruction because the reason is the bowel is either not moving properly, or if it is moving, it is not effective. So the bowel sounds are absent. So what is the reason of such a condition? In this child, the reason is because of the dehydration and because of the multiple episodes of diarrhea he had initially, he developed hypokalemia. And as we know, the potassium is an important component for the bowel to move. So his bowel goes into rest, and this condition is known as paralytic ileus. So what are the causes of paralytic ileus? Paralytic ileus or adynamic intestinal obstruction can occur at many places. There are many instances, like it's a physiological in post-operative patients, and it can be in case of intraperitoneal infection or inflammation. Even it can be found in extra abdominal condition, like somebody is having myocardial infarction, somebody having hypothyroidism, diabetes, spinal fracture, pelvic fracture. So there are a lot of cases of intestinal obstruction which of paralytic ileus. So now how we decide that we are dealing with paralytic ileus or dynamic intestinal obstruction? There are some basic differences between dynamic obstruction and adynamic obstruction. Dynamic means movement. So the bowel is moving against something. So the patient has typical colicky abdominal pain, which is usually absent in paralytic ileus. When you do in the clinical feature, sometimes you will find that the patient is having visible peristalsis in a patient of dynamic intestinal obstruction because of the increased peristalsis, while in paralytic ileus there is no such thing as that the bowel goes into paralysis. When you take an X-ray in dynamic intestinal obstruction, you may come across multiple air fluid level with a cutoff point, while in a case of paralytic ileus, the bowel will be distended from top to bottom, and you may find gases up to rectum, but there will be no air fluid as such, which is typically found in dynamic intestinal obstruction. And when you do a perrectal examination, you may find fecal matter in a case of paralytic ileus in rectum, while it may be absent in a dynamic intestinal obstruction. So these are some of the features to differentiate between dynamic and adynamic intestinal obstruction. Still, sometimes it may be difficult to differentiate between these two types of obstruction. Now about the management. The management in adynamic intestinal obstruction or paralytic ileus is usually conservative. Conservative means you have to admit the patient, put the NG tube so that the distension decreases, give the IV fluids, and take care of the secondary cause which has caused the paralytic ileus. Like if the patient is having sepsis, the patient is having uremia, patient is having hypokalemia, patient is having hyponatremia. So manage all these things, and most of the patients are being managed conservatively. So now the take-home message for you is not all the intestinal obstructions need surgery. There are two types of intestinal obstruction, dynamic and adynamic. Adynamic are managed conservatively. Thank you.